Next, we have Christl from Allina Health, Minneapolis Heart Institute, and she will be discussing navigating aortic emergencies, the patient journey. Christl is a registered nurse clinician who has worked with cardiac patients and families at Allina Health since 2008. Several of those years were in the cardiac intensive care unit, caring for patients following complex surgery, including those with valve and aortic disease. She joined Minneapolis Heart Institute in the Cardiovascular Emergency group 3 years ago and has enjoyed working closely with their aortic program. Katie provides education and outreach to emergency departments, EMS, and transport crews in the upper Midwest to successfully care for medical emergencies and support families during critical events. Katie enjoys sailing and spending time in the Great North Woods. We are so pleased to have Katie share a depth of knowledge on what can be a stressful and scary situation for patients and their families. Thank you for serving our community. Welcome, Katie.
Well, hello. Thank you so much for that welcome. And I'm so thankful to be here today. This is my first Rock from the Heart event, and I know it won't be my last. So it has been a pleasure meeting everyone, and look forward to speaking with you today. So we'll start with just that idea of what does it look like when someone experiences an aortic emergency and during that scary time. First, we'll take a look at the acute aortic syndromes that often present and then subsequently lead to an emergency room visit. So the slide shows the three main types of these conditions. First, we'll start with on the right-hand side. So penetrating aortic atherosclerotic ulcer is essentially plaque that has formed that will start to go through the wall of the aorta. This can be quite progressive, and in fact, it can progress to an aortic dissection, ultimately going through all the layers of the wall of the aorta. Intramural hematoma is essentially just a hematoma or collection of blood that forms in between the layers of the aorta. There is a lot to say about the exact cause of these. Sometimes it's said to be the vessels that surround the wall of the aorta that can sometimes burst, lead to rupture as well. And then aortic dissection, which many of us probably know all too well. And certainly this is the most common of the aortic conditions, and certainly a very emergent at that. So when we look to other things as well, if we have aortic trauma, that can certainly bring us to the emergency room, and then ruptured aneurysms as well. So we'll kind of touch on some of these as we look at that path. We know that aortic dissection is by far the most common, accounting for 85, some literature says up to 90% of these diseases. So when we look at symptoms, we know that the main symptom is going to be this sudden severe chest pain that many of you may have heard described. It can be sharp, ripping, tearing, something sudden that you know that something is not right. It also can be neck and back pain depending on the location of wherever this is being affected in the aorta. And certainly it can go all the way down to the abdominal aorta, so it can lead to some stomach pain. Additionally, then, you can also have symptoms of stroke, heart attack, severely low blood pressure that can eventually lead to an unconscious situation too. And we'll talk a little bit more about that here on the next slide and the reason for some of that. So I like this slide just to show how incredible the aorta and all that it does, right? So it's the largest artery in the body. It supplies many of our major vessels, and certainly supplies blood to our major organs as well. So it's a truly amazing network, but when you see its extensive nature here, you can really start to understand how if something is wrong with a part of your aorta, how many other things can be affected. So for example, if you have a dissection that involves the vessels that supply your head, you can start to show signs of stroke. So any of those symptoms that we're commonly used to, so changes in speech, vision, weakness, etc. If you have a reduction in blood flow to some of the vessels that feed the heart, then you can start showing signs of a heart attack, and you can in fact have a heart attack along with an aortic dissection or another aortic disease. If it progresses further into the subclavian arteries, then you can start to have issue with limb weakness, paleness in your limbs, and other things that can affect that circulation piece. And then as it continues further down, you can have, back pain, stomach pain, etc. Any one of these is a reason to come into the emergency room, right? And even though we know that, I think getting there can be half the battle, right? We have societal norms. Nurses are by far, ER nurses, I think, are one of the toughest group to get to the emergency room, so I can speak that I know that I'm really saying it for myself too. It is important, but I think there's a lot of reasons that we can wait to seek care, right? We start to doubt ourselves. Is this really an emergency? What is the ER like today? Is it busy? Cost concerns? Will it get better if I just wait a little longer at home? I think we've all talked through some of those things. I like to share just one story with this that has really stuck with me. I've worked in the cities here, but I now live 4 hours north of here, and so I was working at a regional hospital up by my area. And there was a call from a daughter who said, "I'm coming in with my dad. He's had severe, sudden pain that started this morning at 8 a.m. It was now almost 6 p.m. By the time he came in, unfortunately, he was almost unconscious. It was a pretty dire situation. And when we asked the reason he waited, it was just because he hadn't seen his daughter and they were fishing for the day. And it's reasonable, but it has stuck with me for years. Because unfortunately, we never know if the path would have looked different. But certainly we had a good 9 hours, where he was experiencing this pain that he described as something he had never felt before. So I think, you're worth it, and I think all your loved ones would agree as well, that coming in when you feel these, regardless of some of those norms that are so ingrained in us, is so important. And we know this, that any one of these symptoms, once we get there, are so time sensitive that we know outcomes improve when we can get, started with the process much sooner. And I know that's something that you probably have heard or have been told, but it is, proven in the literature that time is really important here. So I think the other piece is that once you get there, then we really start a quick process. So you've made it there, and now we need to get to a few things quickly. Any of one of these things would be a reason to call an ambulance. But again, that's a whole nother step, right? Getting there on your own, but then calling an ambulance, and we have a whole set of things that can talk us through that too. Once you enter into the emergency room, for those of you who have not made a visit, that triage process, if you come in with something like, very stabbing, sudden chest pain, that will get you to a room very quickly, and it will probably have, a lot of momentum to that. But certainly if you come in via EMS, that's one of the many reasons why there's certain things that really benefit from that. You get into a room and you get to be seen by a provider right away, and that really starts that time clock. You've made that choice to come in with this symptom, and that's very important. We know that for every, 1 hour that goes past, there's that 1% decline in chance of survival. So it is very important, and I can't reiterate that enough. Once you're there, we really need to start getting to the why, and that's when things can start to feel very busy, right? So we need to make sure that you see a provider quickly, get that physical exam. We know that, chest pain is the most common symptoms with some of these aortic disease. However, it accounts for only about 2% of the chest pain that presents to the emergency department. So a lot of what happens next is we want to try to find out why you're having these symptoms, but also at the same time, what can we rule out, right? And so tests will happen pretty quickly. We have a lot of protocols in place, certainly, for this, and that just really helps us as caretakers get things done in a very systematic and efficient way. So we know that the time of presentation to treatment, again, can mean the difference between life and death. So at this time, you have a room full of ER staff, and they're really starting to look through everything. The provider will start a physical exam. There is certain things with chest pain once they get an EKG, and that can certainly be definitive for many things, including heart attack. Then we start to look at, for aortic disease, we can look at high-risk features, pain features, right? So that's stabbing, sharp pain, any previous risk factors you have, and then anything on exam that may have sparked some concern. And really the idea is, can we put this puzzle together more quickly? So again, we can just really get to that definitive diagnosis. So certainly an EKG, IVs, possibly medications. Many patients that come in with this may have some high blood pressure initially. So as we're getting some of those things started, that certainly will be important. And then imaging. This is really our gold standard to, deciding what you have going on with the aorta and for many other things, but it has a high sensitivity to aortic disease. So certainly that will be in the piece. CT is really good because it's fast. It's usually available 24/7, even in small regional hospitals, so it's something that's readily available to us, and that is also very important. So once all this is happening, this is, very intense. As I know, I've been part of these situations where there's a lot of nurses, providers, other staff in the room. And there's, so much happening. If you are a loved one in that room, it's okay to step out. It's okay to call, a friend, a family member, know that your loved one's being taken care of. But this can be a real stressful time. And I wish we could say that we could calm that room down as much as we could, but really just know that we're aware that a lot is going on, but it's really just for that timepiece, although it can be difficult. So if blood pressure is elevated, we certainly want to try to reduce that. That will reduce stress on the wall of the aorta. So managing heart rate and blood pressure is a huge piece of that. The other is if your blood pressure is too low and we're in kind of a dire situation, certainly then we'd start quick treatment for that as well. So it's really that time we need to get to that diagnosis and really rule out other things. There's, as I mentioned, there's protocols, and I think, we have protocols in place for some of these emergencies, just as we would for cardiac arrest protocols, and that's because it really can get us in a state of excitement. Also, we want to make sure we're not missing anything. We want to make sure we're being very efficient. So those are always being looked at as something as a gold standard to say, we want to make sure that we can accommodate this patient as much as we can. So if you, in fact, get a confirmed diagnosis of an aortic emergency, this is really when a lot of things start to go into place. So first, treatment. And this is really going to depend on the area of the aorta that's affected. So for example, in the arch or the ascending aorta, this is really a surgical emergency. And there's going to be a consultation and some discussion that will include both cardiac surgery and vascular surgery very quickly. If you have an uncomplicated or a stable dissection lower in the aorta, this is something that can possibly be initially managed medically, so blood pressure control, etc. However, that changes to be more of a complicated case if we start to have any signs of limb malperfusion. So for example, things that I was talking about, like the coolness, the paleness, the loss of sensation, etc., or any of the vital organs are affected from that lower abdomen, that would something then vascular surgery wouldn't get involved very quickly. The other big piece of this that can occur between 60 to 70% of cases is someone is presented to a center where they do not have surgical capabilities. We know that transfer to a high volume aortic center does make a pretty vast difference in outcomes for patients. And so a big conversation is now you've had this diagnosis, and now we're telling you we need to get you out of your hometown and we're transferring you someplace else. And oftentimes it can happen so quickly, and it's with very little warning. Just know that we recognize this in the community as this is something very difficult, but the process, if you can understand it, is super important, and that is understood, but there's a lot of things that goes into that, and there's a lot of stress that is now entering your world in a pretty fast manner. So if we can, work with that center to get you accepted and start the process of looking at things. We do that as quickly as possible. Again, understanding that that can be a pretty difficult piece, excuse me. Once you're accepted, so either you're transferring to a center or if you're at an aortic capable center, there's a lot that goes into multidisciplinary communication at that time. So cardiology members, cardiac surgery, vascular surgery are all connected usually via a one-call system. And so then we are all linked together where we can look at images real time, we can start to look at surgical options and treatments. And that can all happen as you're either being transferred or being prepared for surgery. So this is really a huge, important piece to how everyone gets connected in a fast manner. Again, all with the idea that we know it needs to happen pretty, expedited. This is also a time where if you are a loved one, I encourage you to find a family member or a friend that might be able to make some of those difficult phone calls or keep in touch with a lot of the information as things will be happening so quickly. You need to focus not only on yourself and making sure you're okay, but this might be part of the time where you're now going to be traveling to a new city as well, and that comes with a whole different set of challenges. If you do need to be transported, there's a couple ways, and this might be review for many of you, and it might be close to some of you. And so, there's a capability of going via air, and that can go by helicopter or by plane. Certainly, these are for some of the longer distance transfers. We need to also think, though, that even something 3 hours away can sometimes be achieved quicker via ground because we need to get an ambulance from the hospital to the airport, from the airport to the other facility, again to the airport, and then have a ground crew take you back. So we certainly look at timing, and we talk with our crews very closely about proximity and how we can most safely get the patient there. And then, what is really available. Of course, things in this time of year, weather certainly plays a big factor into this as well. So sometimes transport can be quite problematic. I know, for example, up where I am from, or where I'm living now, we have one crew oftentimes at night, and we have one crew during the day with another that's available for transfer. So oftentimes we're relying on our crews around, and again, this all happens very, very quickly in order to make that possible. If you are having a type A aortic dissection or another aortic disease and surgery is available to you and now you've made it to that center, or perhaps you were at an aortic center, the surgical teams have been working hard to not only look over those images but to prepare for the type of case that they're going to do for you. Also, a big piece, and I have a study to kind of look at why over the last couple of years we've looked at this more closely. But we need to arrange to meet the patient either in the emergency room, or sometimes we go directly into the operating room. Sometimes that emergency room stop is simply to sign a consent or meet your surgeon, have an idea of what the next steps kind of will look like for you. Certainly, we've learned over the literature, and again, the study I will look at shortly will just show that we know that there is a significant decrease in time if we can go directly from the operating room, either once a patient arrives or if they are in the emergency room. And that's this here. So this was a study in the American Journal of Emergency Medicine. This was from 2020 in the area around Chicago. And it was showing that adult patients with type A aortic dissection, they looked at 42 patients before they implemented what they were calling direct to operating room kind of program or algorithm, and then there was 84 that participated after this program was in place. And essentially it was, kind of what I spoke about, 24 hours, 365 of cardiology, vascular surgery and cardiac surgery collaboration in order to try to get someone directly to the operating room from an emergency room. And they looked at many that this was being transferred to that center. So what they found was that median time from acceptance of transfer from the emergency room physician to the operating room arrival time was 82 minutes faster in the direct to operating room group compared to the pre-program group, and that was pretty significant. Median time from the arrival to the operating room was 72 minutes faster, again, in that direct to operating room group. And in-hospital mortality went from 16% to 12% in that 84 that did that study. I know, essentially we looked at this was good, right? We know that this was worth some time and it was worth looking into. Since then, I know that we have done some of that, and I think this has been kind of standardized to make it the least amount of stops and complications. I think the only way to avoid that is if they're coming from a center that may not have the imaging capabilities that they need in order to really get to that diagnosis. So they can have the tests ordered, get to the emergency room, and potentially just have a study done on the way to the operating room. But there is very few reasons to make an official stop in the ER, and now it's really just kind of a breeze through. And we know that that is really helping us with some of those times. And really, any time we can decrease that time from diagnosis to surgery, we know we have a better chance and outcomes there. I can tell you that process improvement for aortic dissection and education is ongoing. I help a lot with protocols. This is one example of a checklist that's out there, and really it's just saying, again, we want to make sure these things are systematic. So as we know this heightened situation is happening, we're not going to forget anything, and we know the communication can stay consistent. We also don't want extra phone calls. And so that's why a lot of our join together has been multiple people on the call at one time. So this is just one example. We also have several for our group that we use, but we're always looking to make that process more streamlined, certainly. And I'll just finish up with a few ways that my group does that, and that is with the use of simulation. And we go out to the emergency departments, and I can tell you that when we get requests for what type of emergency you'd be interested in, I would say it's almost always aortic dissection, right? We get a lot of experience with heart attacks, and we even get quite a few, we get stroke and heart attack. People feel pretty comfortable with that. Aortic dissection, not so much. And so we get as much of a request for that as we do with some of our larger resuscitations. And it's for the same reason. We don't see it very often, which is great, but people want to be proficient in this. And so we want to assist them with that. So this is one of the simulators that we have. His name is Hal. It's pretty incredible. He can talk, he can breathe, we can give him medications, and we can monitor what happens afterwards. We can put him on a ventilator. What else? He's pretty high fidelity in the sense of we can get a realistic sense. And so we'll bring Hal out, and then we actually have the other simulator in the room, and yes, we really do sometimes put him in the car this way if we have a van full of things, but we essentially bring an ultrasound simulator out, and then the provider or the advanced practice provider in the emergency room is able to ultrasound the patient and look at different pathologies. He is able to say, okay, we have a positive aortic dissection or other, and then the nurses are able to run a full simulation. And so we can go side to side and really learn from one another. And we found this to be pretty helpful for some of our emergency room groups. The other pictures there, one is in the emergency room too, and again, we started out with a patient who had some crushing chest pain, and we had EMS involved with this too, and so we were able to pull in someone that had called 911, bringing them into the emergency room and practiced it from start to finish. And this is just one way that we can learn to be as proficient as possible and really to ease some of that nervousness that can come with something that we don't see very often, and we know how important it is to do so. And then just the ultrasound mannequin in action. It has augmented reality, so that's sometimes fun. We can see things, we can practice, and it's just an extra thing to make it that extra special. But I will end with that today and look forward to any questions you may have. and thank you so much for your time.
Thank you, Katie. Next, I would like to welcome Dr. Edwin Zishiri from Allina Health, Minneapolis Heart Institute. Dr. Zishiri will be discussing aortic root and arrhythmias, a brief update on the cardiac conduction system in health and disease. Dr.